I am here at the annual meeting of the North American Menopause Society, and I'm speaking today with
Andrew Kaunitz.
And you are?
I'm a professor and associate chair in the OBGYN department, University of Florida College of Medicine in Jacksonville.
And Dr. Kaunitz is an authority on hormone treatment and has been dealing in this area for many years. And he has a presentation here on the long-term effects of hormone therapy. And I wonder if you could speak a little bit about the good and bad and the ugly of hormone therapy.
What you're referring to as ugly, I'll refer to as women's biggest fear associated with use of hormone therapy. And that's the small but important, and I believe real, increased risk that long-term users of estrogen progestin therapy experience. We recognize from Women's Health Initiative data that when we prescribe estrogen therapy alone, for instance, to a woman who's had a hysterectomy, we don't see that elevated risk of breast cancer. If anything, there's a reduction in risk. We're aware of this, those of us whose clinical practice focuses on menopause, but our patients are not aware of this distinction between estrogen-only systemic therapy and estrogen progestin therapy. Many of our colleagues, particularly if they're clinicians who are not focused on menopause, are not aware of this distinction between estrogen progestin therapy, where with long-term use, 3 to 5 years or more of use of estrogen progestin therapy that we would prescribe to a woman with hot flashes who has an intact uterus, small elevated risk of breast cancer, and then with estrogen-only therapy, the best available data indicates no elevation of breast cancer risk with estrogen therapy alone.
So just to interrupt for a second.
Sure.
So for women who have had a hysterectomy, had their uterus removed, and who are taking only estrogen hormone, in fact, their risk of breast cancer goes down.
If that estrogen is conjugated equine estrogen, Women's Health Initiative found that their risk of breast cancer certainly did not go up, and in fact went down.
Are there other points about long-term use of hormones that you want to share?
I would. Initially, a clinically relevant or clinically common patient would be a woman in her early 50s. Perhaps her last menstrual period was a year or so ago, and she's got very bothersome hot flashes and symptoms which are interfering with sleep, and she's seeking treatment. If there's no contraindications, starting her on standard dose hormone therapy often will be appropriate. Standard dose hormone therapy would include 1 milligram tablets, estradiol, 0.625 of conjugated equine estrogen, or 0.05 of a patch. And then if that same patient is doing well for several years on that initial standard dose of hormone therapy, with or without progestin, I would encourage her at that point to try a lower dose, because we know that older menopausal women can be effectively treated for their symptoms with a lower dose.
So it's nothing that says you can't get a lower dose. If you're doing fine after a few years, you could actually try to lower the dose, see if that was sufficient for you.
That's exactly what I do in my practice. And sometimes patients will push back because they don't want to return to those bothersome hot flashes, and they're concerned that with the lower dose they'll sort of be stranded. What if the hot flashes come back, and what do I do then? And so I assure them that if they do experience recurrent symptoms in that lower dose, they need only call, just to call into our call center, let us know what the issue is, and that I will get them right back without an office visit on the earlier higher dose of hormone therapy that was controlling their hot flashes. But what I try to do is encourage women to, over time, reduce their dose. And then once they're on a lower dose, perhaps by age 58 or 61, let's say, that same patient who started in her early 50s, now perhaps she's on a lower dose, 0.5 of oral estradiol, or 0.3 or 0.45 of conjugated equine estrogen, or perhaps a 0.0375 or 0.025 transdermal estradiol patch. At that point, when she's been symptom-free on that lower dose, perhaps for a few years, then we come to a crossroads. If that patient is at normal risk or low risk for osteoporosis, and she might be at low risk if she's overweight, and many of my patients are overweight, then I would encourage her to try stopping hormone therapy. And if she stops and has no symptoms, she can remain off hormone therapy. If she stops and has symptoms, again, with a phone call, she can get back on the dose that was controlling her symptoms. But the other group of women, as we reach this threshold, would be women at elevated risk for osteoporosis. Perhaps her mom had a hip fracture. Perhaps she's a very slender woman with a BMI of in the low 20s or even lower, as some of my patients are.
That's meaning a very thin person.
A very thin person. So there I would be interested in encouraging that woman to continue a low or ultra-low dose of hormone therapy, perhaps even indefinitely. And there we can also reduce our use of progestin in the hope that this might reduce any impact on breast cancer risk, or even consider, when a uterus is present, using an ultra-low dose of estrogen alone, paying close attention to women who might report any spotting or bleeding, recognizing that they would need evaluation. In my practice, it's not unusual for particularly slender women and those who have extra concerns with respect to risk of osteoporosis and fractures to continue low doses of hormone therapy long-term or perhaps even indefinitely.
Well, thank you very much.